Good morning, all. Dear friends, very good morning. It's a very fine Sunday. I welcome you all to the small but very essential session. I'm Dr. Onlay K, CD convener from Alabama. I'll be moderating the session today. The faculty for the mentor for today's topic is Dr. Patik Patel from Ahmedabad. Today's session is not just about filling teeth, it is about problem solving. Patients come to our clinics to saying that we don't have time to come for another appointment for crown, then we should not, send those patients back saying, no, sir, this is not possible. We will need at least 3 days for the crown to come and all that. No, patient has got a problem. We will solve that problem for you. That should be our attitude. And today, we have a very able mentor. He passed his BDS in 2015, 2011, MDs in 2015. And since then, he has got a very high-tech, modernized clinic in Ahmedabad, A to Z dental care, and he's also conducting courses for fellow BD students for the upliftment of dentistry, to teach us new topics. A to Z Dental Academy. Very able guy. He has presented and attended many international conferences and conducted a lot of classes also. Pathik sir, I welcome you to this webinar. Over to you, sir.
Thank you so much. So, am I audible?
Yes, sir. Very fine.
Okay. So, should I start my webinar?
Yes, sir. You can start.
Okay. So you'll have to share.
You can share your screen. Yes, sir. Try again, sir.
Right. Now it's possible. Visible?
Yes, sir. Visible.
Okay. Right. So good morning, everyone. It's a lovely Sunday, and thank you for bearing me on this beautiful Sunday for next 1 hour 15 minutes. And so as Mr. Unikrishna, Dr. Unikrishna told, today is a very important topic, a small topic, but a very important topic because many of the clients in our clinic, I prefer to speak clients rather than patients, but it's okay, it's my choice. So most of the clients that come to our clinic or our practices now are, highly urbanized. They want every treatment to be, in one shot, maximum 2 visits, and multiple teeth treatments they want in 1 or 2 or 3 visits, not like initial days where you call them for 10-15 days. Nobody has time currently. And in these situations, the bread and butter of dentistry that we consider as crown and bridges, okay, mostly the crowns. So if you have a patient where there's a big white class 2, is it a pulpitis case or it's just a routine class 2, doesn't matter. But in those cases, if sometimes you feel that direct restorations won't last long in this patient because of bite, because of his hygiene, because of the depth or the width of the cavity, etc. In those cases, what to do? There are two more challenges. The patient tells, doc, I just have half an hour or 1 minute, 1 hour or maximum 2 hours today. So, you have to forget about the crown part or the indirect restoration part. And the second is, his bite would be very deep, or you may find challenge in building up the contacts and contours, etc. So in those cases, what would you do? If you don't know how to prepare an immediate chair side inlay, onlay, or even a crown that's called endocrown over a root canal treated teeth immediately, chair side, within an hour or 1.5 hours, then the patient, the client may, be not be fully satisfied with your treatment or with your planning, and he or she may, go to another dentist who maybe knows this kind of treatments. So very important topic for all of us. I'm going to present it in the most easiest manner possible because I believe in practical dentistry. Very very less theory. So only first 5-6 slides are probably just basic introduction history. and one or two slides of little theory, which is little mandatory. Otherwise all the entire slides are completely made up of cases. I have 10, 12 cases, different cases to show, where you will know which are the indications of making a semi-direct chair side, that is immediate inlay, onlay, or an endocrown. So let's start. Okay, so these are the pictures where you can see this is an inlay. Inlay mostly is an intracoronal restoration. Onlay is considered as an intra as well as extracoronal restoration, where the cusp capping is done, mostly all of the cusp or at least 2 to 3 cusps. Inlay can also have cusp capping of one or more cusps, but not all cusps. And this is the crown, where entire it's an entire extracoronal restoration. Okay, you can also call it as overlay, tabletop, or so this is also crown. Now, this thing which you see, the thing which has this big prominence is called endocrown. It has a crown as well as a big prominence. This prominence goes into the pulp chamber, okay, in your root canal treated teeth. And this is the crown part. So entire thing, endo, because it involves the pulp chamber, the endo part, and it has an extracoronal component, that is crown. Hence, it's called endocrown. So for today, we are going to speak regarding inlays, onlays, and endocrowns. So why are we talking about inlay, onlay, and endocrowns actually? Little theory as I told. So today, indirect restorations are seen as preferred form of treatment, okay, in posterior region, and a viable alternative to a full crown or a direct restoration, right? Direct is a direct composite restoration, or silver amalgam wide large restorations. So there are a number of associated factors. The result is an aesthetic and functionally well integrated conservative restoration, conservative in comparison to the full crown, which allows both restorative corrections prior to cementation and late repairs. See, why are we talking more about indirect restorations, especially composite indirect restorations? We are today not going to speak much about indirect ceramic inlay, onlay, because those things can't be done without a lab support, or if you have a CAD CAM milling machine besides you, still it would take few hours. Let us consider if we have a patient in which we have to make an immediate chair side inlay, onlay, or an endocrown in less than 1 hour or at least 1 hour, then what to do? So these are the associated factors why indirect restorations are seen as preferred form of treatment. Okay, because aesthetically, functionally, they are well integrated. Conservative restoration, corrections can be done. If the patient comes after 6 months, 1 year, 2 years, there's some fracture, it's a composite, so you can do the correction direct with direct composite. Prior to cementation, if you feel that okay, I need to add some composite, then I need to cement this inlay or an onlay, it can be done. Endodontic revision. So for example, if after making an inlay or an onlay, if you want to carry out a root canal treatment, for example, the client has a TOP positive, or severe sensitivity because of the nerve pulp involvement, then you can carry out the endodontics, without that main drilling through a crown or a ceramic inlay onlay. So these are the various advantages you can get. Optimal occlusal anatomy, which you can build outside the mouth. Okay, any anatomy or contacts which you can build outside the mouth are always, there is no saliva, no blood, and calmly you can do. Your patient is not undergoing any musical, you know dance steps while undergoing the treatment in mouth, anything. So optimal occlusal anatomy and contact points without complications, sometimes associated with the direct restorations, can be done. So what's the history? The problems which are associated with direct technique resulted in the development of semi-direct techniques. Which are the problems which are associated with direct composite techniques? High shrinkage of composites, because if there is a wide, deep carious lesion, you have to do multiple layers. Today, in the era of bulk fill composites, yes, that problem is majorly solved. But what about the wide lesions where a lot of composite is going to come and it is going to shrink and create shrinkage stresses? So high shrinkage, thus restoration failure in the form of micro leakage, fracture, tooth sensitivity, etc. So Mormon et al., Blackhenio et al., and Mormon et al. Again, with the aim of improving the quality of large class 1 and class 2 restorations, developed the semi-direct techniques around 1990s. Just excuse me for 30 seconds. Just a minute. Okay. I'll again share the
Right, sir.
screen. There was some issue regarding it hung up. Okay. So back again. So what are the disadvantages? Okay, this is also important because today we are going to speak about immediate chairside inlay, onlays, and endocrowns. Okay, immediate, that is done with composites, but outside the patient's mouth and immediately, not like taking impression and giving it to the lab and they make the indirect ceramic or indirect composite inlays or onlays. So the disadvantages which are associated with the lab fabricated, okay, lab fabricated is indirect, and the immediate chair side that we prepare is called semi-direct. So what are the disadvantages of lab fabricated restorations? Dental lab costs and associated time required along with it. So, cost of for the patient and the patient compliance. I'll give you a small example. Uh, One day what happened, I started a class 2 cavity preparation in my one of the patient which had vital teeth. Okay, and I had suspected that it's a deep carious lesion, but eventually it became wide enough and one of the cusp was had less than 2 millimeter of remaining dentin, almost only 1 millimeter. So I had to grind that cusp, particular buccal cusp, and had to perform the cusp capping. Now in those cases, and it was a very wide, so it was having broad contacts and contours. So then I had charged 2000 rupees for the deep class 2 direct restoration. Now if such thing happens, and now that this case is not for a direct composite, this is a case for indirect restoration. Either you can end up convincing the patient for a crown, which is not good because it's aggressive, or you can carry out a indirect inlay. Indirect, that is just take the impression, prepare properly, take an impression and just send it to the lab and it will be done. But as you know, the indirect ceramic, that is lab fabricated ceramic inlay or onlay, would cost you around 2,000 rupees lab cost. So you have to charge minimum 8 to 9,000 or 10,000 rupees, to your client. Now, if I tell the client, boss, sorry, at this point of time, this 2,000 rupees restoration is not possible. I'll have to do this ceramic inlay restoration and it would cost you, sorry, but 9 to 10,000. Patient is going to scare hell out of it and he's going to jump and just go out of your office. And most of them, some of them, you may be lucky that say, okay, no problem doctor, you do the best. So you can't lose a patient like this. So in those cases, what would you do? If you know this technique, at least for that period of time, you can do that and maybe explain the patient that if this somehow doesn't work for a long time, then we will make this indirect inlay, which would cause this. Okay, so that's why this knowledge is very important. Higher loss of healthy dental tissues are associated with the need for divergent walls. So you would know that for an ceramic inlay or onlay, a 12-degree taper is actually required. And for the composites one, 6 to 8 degrees is more than enough. At least 2 sessions are required. Okay. So this is the world of indirect restorations. This is the lab fabricated ceramic onlay, as you can see. Okay, lab fabricated on the cast. Again, a lab fabricated indirect composite inlay, that is again on the cast. But see this here, you may feel it as a red color cast. No, this is an addition silicon material, rubber based material, that's called disilicon from Voco. And I'll let you know how to prepare this. But on this die, or on this silicon die, we are going to prepare semi-direct chair-side fabricated composite inlay, onlay, or an endo crown. So these are the three variations that you encounter. Now the indications for indirect restoration. Okay, I'm talking of a general indirect restoration, indirect or semi-direct. Wide spacing between two adjacent teeth, more than 0.5 mm. Broad contacts and contours that need to be developed, which is very tough to do in an direct intraoral restoration. Aesthetic zone example, premolars. So aesthetic zones where cusp capping is required, you would need a extraordinary proper shade, everything aesthetics. So heavy occlusal stresses, when the heavy occlusal stresses are suspected, direct composite restoration, which is already undergoing a lot of shrinkage, you may feel that heavy occlusal stresses can lead to failure of the direct composite restoration. In that, indirect restorations with excessively high wear resistance and the hardness is very important. Contraindications for indirect restoration, yes, these are important. Poor oral hygiene, because their cementation protocols are quite delicate and complex. Isolation difficulties, as I told, if you can't isolate with rubber dam, it's tough. Sometimes you can do with cotton rolls and etc if the patient has less saliva, but if heavy salivation, especially in lower molars, tough. Economic factor, yes, economic factor does come in indirect restoration. It doesn't come much in the semi-direct. Inexperienced, lack of skill, yes, and lack of healthy enamel, yes. If there is lack of healthy enamel, I mean, no, indirect restorations or any composite restoration needs lot of enamel, especially in the margins, a healthy enamel. Only then there will be proper bonding and no chance for micro leakage in future. Advantages, it's conservative, adhesively bonded, so great strength, yes. Increased wear resistance, yes, one of the most important feature. Excellent polishability, indirect restorations can be polished extraorally, right? So they can be polished minutely from each and every areas. Even the proximal areas can be polished. And mostly very important, why we perform onlays or an endocrowns even for a root canal treated teeth, because most of the areas, that is buccal, lingual, mesial, distal, occlusal, everything is probably going to be above the gingival level, much above, right? It's not just supragingival 0.5 to 1 millimeter. It may be 2 3 4 millimeters above the gingiva, above the periodontium. So there is no possibility of any biologic width hampering or foot lodgement or any further gum recession issues. So somehow sometimes it's sticking up, so I'll have to do this way, please bear with me. So which are the advantages which are procured by the use of semi-direct composite restorations? Okay, minimizes the effects of polymerization shrinkage and reduce its stress effects on cavity walls. Why the shrinkage is reduced in uh, outside the mouth? Very simple, because there are no dentin or the tooth walls that are present to bind the composite towards them while it is getting cured towards the center of the mass. This is called the shrinkage stress that develops in the bonding area over the tooth at one point and the composite restoration at the other point. So there is almost no effect of polymerization shrinkage. Polymerization of composite takes place as a whole, because you can cure it from all the parts, even from the base of the composite. mostly that thing we cannot do in the patient's mouth, that we cannot cure the composite from the pulp level. But in this, outside the mouth, we can cure it. We can cure it from the proximal level also, as much as we want. So polymerization of the composite as a whole, eliminating the risk of remaining free monomers. Better adaptation, yes, better sealing, better occlusal anatomy and proximal contacts can be developed, especially for those kind of cases. Better aesthetics, yes, and most important, best mechanical properties are developed during thermal and photonic treatment in the laboratory. So the preparation designs, mostly the preparation designs are same as of any indirect restoration, that is inlays or onlays. The taper is around 6 to 8 degree. You can even carry out a 10-12 degree taper in the initial few cases, because it's still not the easiest way to do a semi direct restoration. It will take you 10, 12, 15 cases to master this thing. I am going to give you lots of tips and tricks, but still, once you do it, you'll know. So as you can see, no undercut should be present. Okay, it should have good proper taper, as I told, flare of the walls, and there should be all over healthy enamel for the bonding to take place. Okay, the depth of cavity is important. Normally 1.5 to 2 millimeter is the proposed minimum depth of the cavity, especially at the occlusal level, that is required. Cusp capping, if you are doing, make sure the cusp area, the tip of the cusp area, which you are going to produce, would have minimum 2 to 2.5 millimeter of thickness. Okay, because composites less than 2 millimeter of thickness would maybe break, because of the they become more rigid when you do it outside the mouth, because of their higher monomer, higher degree of monomer conversion. Okay, again it has stuck. I don't know why it's getting stuck for some reason. I think a lot of people are getting admitted in between, so probably I'm admitting them in between.
No, sir, I'll take care of all that, sir.
Okay, so I think I should not
Yeah.
do that, because
No, no, you just
that's why it's, that's
carry
why
with the
it's
class, sir.
sticking quite a lot.
Right, sir.
Fine. So this is not my case. It is just a case to show, because of the very nice preps that have been done. This is my case. So in this case also, if you can see, there are no undercuts. There is no overhang enamel anywhere. Yes, before carrying out the impression technique, you have to finish these all margins with your yellow band, that is extra fine, super fine burr. Okay, or you can do with your micromotors, uh, finishing discs or burrs. Okay, but it has to be properly finished. There should not be any overhanging enamel or dentin. What is the armamentarium that is required for indirect, semi-direct restorations, that is immediate chairside restorations? Very important, you need a high precision alginate impression material. A regular alginate may not produce a very good impression. Okay, silicones are not indicated to take impression, the C silicones or the A silicones. You have to take it with a high precision alginate impression material. This is the technique that has been advocated. Okay, this is the most important and the only material available in market, disilicon. So after you take alginate impression of that particular cavity, or the tooth preparation, you have to pour this disilicon, just like you pour your light body or your stone in the cast. Okay, there is this quick mix syringe tip also, and then it sets for about 2 to 3 minutes, and after that you can remove it and immediately start performing your layering of the composite. So it's that quick. And of course you would need a very strong compatible composite material. There is nothing like you have to use a particular brand of composite, but I would advise you to use a nano hybrid composite, no micro hybrid, no nano field, but one of the nano hybrid composites which are available, one of the best in market. Why best? I will explain you. Because of the high filler content, which is very important for posterior areas, especially where you need excessive strength and resistance. And it should have radio opacity, so you can even visualize in x-rays in future also. So polyfill NHT is one of the such materials. It's a nano hybrid material with extreme high filler content. Yes, in today's era where you are exposed to a lot of bulk fill materials, you can even use bulk fill composites in this kind of cavities where you can just completely fill up the dentin part of the cavity with the bulk fill composite and then layer the enamel part with kind of polyfill NHT kind of materials. Polyfill NHT is a material which has its flexural modulus, elasticity modulus, that is, the fracture toughness strength as same as that of dentin or higher than dentin. Okay, that is almost 17 GPa. Dentin has around 17 GPa. Enamel is around 30-35 GPa. No material, no composite material has more strength than 17 to 20 GPa in market. Okay, so this is one of the highest flexural modulus property in market. So such kind of other bulk fill composites which are there in market with highest filler content and lowest possible shrinkage and shrinkage stress, very important, are extra fill. It's a 4 millimeter bulk fill from Voco. Admira Fusion Extra. Okay, Admira Fusion Extra. It's a pure ceramic based composite, one of the purest in the world, the purest silicon oxide based composite. Okay, it does not have classic methacrylate monomers in it. Everything is based on glass ceramics. So that is Admira Fusion Extra bulk fill, and Everex Flow, that is a fiber reinforced composite from GC. So one of the composites you can use as a 4 or 5 bulk fill composite, and then you can just layer 1 millimeter or 1.5 millimeter of the enamel by polyfill NHT or other kind of nano hybrid strong composites with high filler content and low shrinkage. And once that is done, how to cement it? So you need a dual cure resin cement. I would advise you to read the instructions for the dual cure resin cement that you may be using in your clinics. If it's written inlays onlays cementation, but composite inlays onlays, I would prefer you to use that material. Most of the materials don't have that composite inlays onlays written in it. Okay, so this is the material. Of course, I would prefer using a particular company things in especially such kind of delicate procedures. So using particular disilicon, then almost if possible you have a good range and budget of materials, then Voco is one of the best dental material company, especially in restorative segment. uh, so you can use the same company Bifix QM. It's a dual curing universal composite based luting system. It has these three bonding agents, in which one is the silane coupling, which is known as ceramic bond. And there are two bonding systems, liquid 1 and liquid 2, which is called Futura Bond DC. It's a self-etching, self-adhesive bond. Okay, that means there is no need for etching if you are using Futura Bond DC. It has mild conditioners in it along with bonding agents. So it will do the job of your etching as well as bonding. Now this is one of the last slide and everything will be now case oriented. But this is very important slide. So which are the situations that demand the use of semi-direct chairside immediate restorations? Please concentrate on last two things, because the other all things I have photographs to show you that this is the indication or the situation that may demand the semi-direct chairside immediate restoration in your mind. It is a doable kind of restoration for a teenager, that is a 14, 15, 16, 17 year old, to avoid a full cast crown for a few years. Sometimes you have a patient, a child, that is not basically a child, a teenager around 13, 14, 15 year old, who has a first or a second molar that is grossly carious, probably a first molar, and it has the second molar has maybe slightly erupted, partially erupted, or fully erupted, but still you want to avoid crowns in that young age. What you can do is you can perform this kind of semi-direct chairside immediate restoration that would last for few years. Okay, I have cases where since 1.5 2 years I've been performing this, so I can tell you it has not fractured till now. But at least for 4 or 5 years, these restorations can do good. So you can consider them as semi-permanent to permanent restorations. And it is an economic option for an ceramic inlay or an onlay. The other situations I'm going to explain you in these slides. So which is one of the very important situation most commonly that you encounter is a wide and or deep carious lesion which is having a vital pulp. So this is the case where I had an idea that, see, initially only it is having a wide cavity, and of course the X-ray would show that this is a deep carious lesion. There is a metal FCC, for example, in this case, which is having a flat occlusion but a very wide occlusion. So after removing the carious part, such wide flat occlusion is tough to be made in a direct restoration with challenges of shrinkage and all. Plus, it's deep enough. So, I have to do a lot of layering and etc. And, band, wedge application, it should be precise, so, absolutely perfect. So in such cases, you can decide to do a chair side inlays if the economic factor for the patient is important. Another very important feature, you might have so many clients that come to your clinic with your own or another dentist's fractured composite restoration directly done, especially the class 2s where they are hanging inside the gingiva, or they are mobile within the cavity but not coming out, or whatever reason, due to extremely broad contact areas or some natural spacing between the teeth. For example, see this X-ray. This is not a case for a direct composite because of the spacing in between this molar and this premolar, and it is the most, see, it's the marginal ridge area for an upper first molar, which is the one of the most under heavy occlusal stresses. So a direct composite restoration, if you over built up, it's not going to stay properly. Another indication is replacement of old large amalgam restorations. Okay, say this large old amalgam restorations in this premolar, that is the aesthetic areas. This buccal cusp is also in aesthetic area for broad smile, if the client has a broad smile. So when you are going to remove this silver amalgam, some black part is also there because of the corrosion products that are developed. Hence, it's a wide cavity and you may need to cap the cusp and everything. So in those cases, you can opt for a semi-direct or an indirect restoration. This is not my case, but just in one of the indication that multiple restorations by quadrant easier technique because it requires a single impression. So when there are 4 or 5 fillings, multiple fillings in same line, what you can do is you can take an alginate impression, you can pour it with disilicon and work outside the mouth, for all these cavities and cement one by one, rather than restoring one by one each and everything, and it's a heck of a job, especially for these wide lesions. Immediate semi-permanent crown type treatment needed. For example, yes, as Dr. Krishna told in the beginning, if a client comes to your clinic, if he or she is a celebrity or a corporate one or a cricketer or someone, a sports person who has to go leave the town or a city or the country that day or next day or within 2 days, and if he or she needs such kind of restoration, probably a root canal treatment followed by a crown. If you don't place a crown, the tooth may fracture because of, for example, this is the case where the palatal cusps, the functional cusp of the upper first molar, is destroyed because of the cavity. So you need to give the patient a strong direct composite filling, but that would then again shrinkage issues. Or better is you can give a composite onlay, or in this case it would be called as an endocrown. How to do so, I'll show you this case also. Now, avoiding deterioration of periodontal condition. For example, in this case, this patient was a carpenter and couldn't come again. So I performed a single sitting root canal treatment and see the hygiene. Okay, so of course I did the scaling, cleaning of teeth, but eventually I know that he or she is not going to maintain it properly. What if I give a metal FCC or a ceramic or an all ceramic or a zirconia FCC? I mean, he or she is not going to maintain it, and the periodontium of this area will be ruined. So in such cases also, we can carry out the semi-direct composite restoration, which will be better for such kind of atreided cases, deep bite cases, because of the wear resistance of composite, the semi-direct one, rather than the direct one. And secondly, it is mild to the opposing teeth as compared to ceramics. Yes, let's begin the case series. First, wide, deep, carious lesion. So I showed you this picture. Okay, so this was a deep carious lesion. Yes, patient didn't have complaint of irreversible pulpitis or any other thing. Was normal food lodgement issue and mild sensitivity to cold stuff. Okay, that goes away as as soon as the stimulus is taken away. So this was the pre-operative picture. After removing the decay and giving it a proper proper flare up, proper taper, this was the situation that I encountered. See, over here it's almost 2 millimeters beyond the contact point. Over here it's almost 0.5 to 1 millimeter beyond the contact point with the adjacent teeth. So these are the cases indication where it is recommended to do a semi direct or an indirect restoration rather. Okay, what I have done here, in those cases where it's a kind of an indirect pulp capping case, you may put a calcium hydroxide or a glass ionomer cement restoration that covers the deepest layer of the dentine here. Okay, it is also known as immediate dentine sealing. Sometimes you can even use just your fifth generation bonding agent that will seal that area of dentine unnecessarily, because this area would remain exposed for 30 minutes or 1 hour until and unless you are going to prepare the composite outside mouth. Next, now these are the techniques which you do. First, I'm going to show you the techniques how to take the impression, how to build up the disilicon, and how to build up the composite. Cementation protocol step by step will be at near the end. Okay, so we are not going to get confused because cementation protocol is a very delicate, complex protocol. First, what we are going to do is I took the alginate impression. Okay, this is the alginate impression for that inlay. Over that alginate impression, I poured this disilicon, okay, in that cartridge gun, dispensing gun, and inside out. So your this syringe tip should remain present at the deepest point of the cavity, and then you have to give pressure to the cartridge gun plunger, and there will be flowing of this disilicon addition silicon material in the cavity, just like you do a light body. One thing you have to make sure is the tip should not come out of the flowing material. It should remain within. Only then there won't be any bubbles and you will have a very nice bubble-less, near bubble-less disilicon dye. So this is the dye that will be, you have to remove it from the alginate impression. It is so easily removable with your plastic filling material or a spoon excavator. Okay, and it won't break, don't worry, even the alginate won't break. And that can be done after 2 or 3 minutes of its setting time. Then what you can do is prepare this kind of an inlay layering technique. Yeah, you can first make up the proximal wall, then you can build up the remaining cavity as a class 1 cavity, or you can build up step by step horizontally upwards as and when you feel. Everybody develops their own different techniques. Okay, nothing is wrong, you do what is comfortable to you. So here, as you see, this is, so even with a BP blade you can cut this disilicon material very easily, and you can, once you have completed your restoration, what you can check is if it is having any overhang. You can even check few of the contact points if they are rough or not. You can polish these areas, proximal areas, which you cannot perform in a direct restoration in patient's mouth. Or if you can perform, you cannot see, you cannot visualize, you're doing it with your strips. So these are the advantages that you procure when you are carrying out a direct or a semi-direct a semi-direct or an indirect composite or ceramic restoration. Okay, you can give nice anatomy, you can give some stains. It's okay, this stain part you can give, you cannot give, it's okay, it's based on everyone's liking of this particular technique. You can give some basic grooves and all. One of the small disadvantages of these techniques compared to the lab oriented techniques are, you cannot spend time in mounting the casts and everything. You are not making a cast in this. Okay, so in those cases, uh, intraorally you may need to spend 15-20 minutes to adjust the occlusal area. Yeah, I do agree with it, but that's 15-20 minutes, it's not more, and it's a composite, so it can be easily adjusted. So which are the tooth preparation phases for indirect composite resins? Occlusal divergence, as I told, 5 to 15 degrees the range. 6 to 8 or 10 degree ideally should be given. Round internal angles, butt joint preparation margins. This margin should have a 90-degree angle with the axial wall. This margin should have a 90-degree angle with the gingival or the axial wall. Immediate dentin sealing can be done using adhesive procedure and rubber dam. As I told, unnecessary, the deep layer of dentin should not get exposed to saliva oral bacteria. Blocking out the defect related undercuts. If there are undercuts, for example, in this area, if it's quite deep pulpally or axially, I can block out with a glass ionomer cement and make it divergent or tapered. And finishing with the diamond burrs and silicone points. Finishing of preparation is very important, as I told. So see, this is the final case of the inlay that I have prepared. See the context and contours that I got. This is one of the other view. And look at this post-operative radiograph. Absolute hermetic seal. Which luting system I used for this inlay? I used the Bifix QM. I'll show you the material again along with the entire cementation protocols. First, let's see the cases, how to prepare, how to take impression, and how to build up. Okay. So this is one of such case. It was a deep case, but luckily I managed it properly. One of the other material that you can use to lute these inlays is a direct flowable composite, not a routine composite, a high filler content, because eventually the cementation, the cement that we are using also would take some of the discrepancies in the margins, especially at the gingival seat areas. There will be some discrepancies where your cement will be exposed to oral environment and not entire inlay. So those the cement that you select has to have a very high filler content, a great strength, and a minimum shrinkage. Dual cure resin cements are best, but if you want to use a direct composite, then the Grandio SO Heavy Flow is one of the highest filler content, lowest shrinkage flowables, the regular conventional flowables in market. So if the inlay depth or the width is less enough, it's not quite deep inlay, it should not be an deep onlay or an endocrown, but for inlays you can perform or you can use the Grandio SO Heavy Flow kind of flowable composites to lute these inlays. And then because the light should reach at great depths for the direct composites to cure. Okay, that's why we are not using direct composites generally to lute any of the indirect restorations or even posts in the post endodontic restoration. Now I am going to show you one of my case which went wrong at the last step. Okay, you would be surprised to see it is such a good case, but when you take the post operative x-ray, you know where you have missed out. So what to do in such cases? It's a I learned from my own mistakes. This is one of such case. See, this was having a wide lesion. It was a deep cavity which was near pulp, but entirely vital. There were no signs of a chronic apical periodontitis or even irreversible pulpitis. This is the cavity prep that I did. If you can see here, there is a small undercut. Okay, so I need to finish or give a taper to such kind of undercuts. Okay, I took the alginate impression. This is the disilicon model that I have prepared. This is that same model. As you can see, after preparing this composite restoration, because it's quite deep, see if you can see it's subgingival at this point and it is equigingival at this point. Okay, so here the impression taking would be tough because alginate impressions so deep probably cannot record the finest details. So, I had an overhang, but this is the advantage, because this overhang, after cutting this with the BP blade at this level and create a proper die cut in this die model, I have to finish polish, and then this is the finished and partially polished version. If you can see, so nice. And this is the finally cemented version. Have a look at this. It looks so beautiful. Okay, most of these inlays or onlays that I have prepared for the cases, I have done with Polofill NHT. One or two cases I have used extra fill as a bulk fill material to layer the dentine part, and enamel you should never layer with a bulk fill material. Enamel part should never be layered with an bulk fill material, because bulk fill materials have less flexural modulus and enamel needs rigidity. Remember this, okay, even for direct restorations. So this is the fine, super fine. I was so happy with the restoration. See the contact contours, shade matching, everything is beautiful. But unfortunate event. Have a look. Really unfortunate. After 1.5 hours of this entire restoration from start to finish, and it had this big marginal defect at this point. No doubt I was happy enough that at this area there was my cement as well as the indirect composite that I semi-direct composite that I prepared. But what about this area? There will be secondary caries that will happen, and eventually I may have to repeat this or create carry out an endodontic treatment and go for an onlay or a crown. Why did this happen now? Okay, let's learn from my mistake. The point is this part. Okay, this is the subgingival, the gum part that happened with me. Why are these lines coming? Unfortunately, I am not carrying out these lines. Okay,
Right, sir. Yeah.
so what's the reason? These lines.
Uh,
Anyways, should I stop and again carry out?
yes, sir. Maybe if you stop share and start your screen share once again, it will do. Right.
Okay, because my kid is not around me, so nobody can do like that. Okay. Okay, right. Now I'll again share my screen. So this is a small break, okay? Consider it a forced
Yeah.
break. Okay, and now we are in the middle of the presentation with so many good cases to show, right? Finally, lines have gone, thank you. And yes, so in this area, what actually I need to do is I need to elevate the margins at the gingival area. So I have to first go for a regular band and wedge as a direct composite class 2 restoration, and I have to use a GIC or a bulk fill or a dual cure resin cement to build up this gingival seat area so that it comes supragingival by about 0.5 to 1 millimeter, and then I need to take the impression so that particular impression would come and such kind of thing won't happen. So this is one of the very important tips that you have to take care. Another case of failed old composite restoration, direct composite restoration, as I told. So I don't have so many pictures for this case. This is a case of a dentist herself who came to me that I got this done by another dentist or previously, and it keeps on coming out, it keeps on breaking, like it has been done 3 times till now. So what I did is, I took the alginate impression, poured the dye silicon, cut the dye, and then see, this is a huge contact to build up. And of course, she is a dentist, so she doesn't want a crown. And yeah, I could have done the indirect ceramic inlay onlay, but when I explained that this can be done, she was very happy that, yeah, you did do this. She has a small child, so she couldn't come again for the appointment. So such kind of cases also, they are very helpful to you. You are already anesthetized the client, so you can perform it in single visit. And this is the result. Have a look. See, in this you may feel it's an open contact, but it's really not. 6 months have passed, and this because she's a lady doctor and she's my friend, so I'm in contact with her. And she also had that sensitivity complaint because of that failure direct composite. But here, after that restoration that I did just before the lockdown, I think I did her restoration on 18th or 19th of March, and from 22nd we all are in lockdown. So she just came August 1st or second week, so around 5.5 months, and it was absolutely superb. The restoration was as polished and finished as you can see here, not even a single stain, and no fracture point, no crack point, and she didn't have a single sensitivity. She came for another side restoration, which I did. It was a class 1 cavity restoration, which I did with a direct composite. So these are the cases that will help you save the client, save her teeth from getting root canal treatment as well as crown. Replacement of old and failed amalgam restoration. See, in such cases, this was a failed amalgam restoration that was already repaired with a direct composite few years back by me only. But then the patient had problem with the aesthetics also. So I had to replace it. After removing all the silver amalgam, have a look at this remaining cusp. It is so thin at this point. There is very less dentin, less than 2 millimeters. So I had to cap the cusp, as you can see here. See the preparation. A healthy enamel, thick enamel all around. Have a look. And the taper, the finishing, everything. There should not be any undercut. Okay. Even here, see this buccal cusp, entire buccal cusp and lingual cusp. Lingual cusp was not that much involved, but still it is an upper tooth, so it is under good occlusal forces. Hence, I have trimmed down the lingual cusp by 1.5 to 2 millimeter, the palatal cusp, sorry, and the buccal cusp because it became very weak and it was kind of an onlay MOD. So, see this thick, healthy enamel lining all around. This is very important. Such case, see, I performed this alginate impression, very nice alginate impression with high precision material, and then poured it so that disilicon model is there, and above it around half an hour time it took, but I properly layered it. We can give good amount of different shades. You can give good occlusion, you can give some stains, everything. And eventually, see, after finishing polishing, most of the occlusal stains and everything is gone. One of the small disadvantages that you may have performed a very beautiful restoration outside mouth, but eventually it may be little bit uh, you know like this. uh, please keep admitting the participants. I can see a lot of them coming around. Okay, so and then after finishing polishing, adjustment and everything, look at this beautiful shade matching and aesthetics that you can find. Have a look. Nobody can see or identify that this is a different restoration that you can see. Okay, have a look at this aesthetics and everything, plus the advantage here. The restoration is 1 to 2 millimeters above the gingival level. Hence, there is no chance for future periodontial regression or gum recession in these areas. So this is very, very important for any indirect or a semi-direct restoration rather than crowns. So this is the pre-operative X-ray and this is the post-operative X-ray. Have a look at the molar restoration. Beautiful as compared to this old one. Pre-operative photograph, post-operative photograph. This was done about 9 to 10 months back and everything is fine. Look at this tight contacts contours. Here, if you can see the pre-operative photograph, there is wide spacing. There was some tartar, some food lodgement that was in between these two teeth also, which we have solved with the indirect restoration with broad contacts and contours and tight contacts. Now I'm going to show you 3 to 4 cases of a very unique treatment option for a root canal treated teeth. That's chairside fabricated composite endocrown. Okay. See, this was one of the case where because of high attrition, patient was a carpenter, uh, periodontal deterioration was there, and I had to perform a single sitting root canal treatment because of for a cracked tooth syndrome case, and then a crown. So I opted for composite endocrown. So after performing root canal treatment, what I did was, 2 to 2.5 millimeter of clearance, occlusal clearance. If you can perform 3 millimeters, it's best for an endocrown or an onlay because of the strength that a thick composite needs. And see, this is my preparation. All around there should be healthy enamel. Only at this one point, see, have a look. I improved from my mistake. This is the class 2 gingival seat area that I have built up with a flowable composite or a dual cure composite or a GIC, and got it above the gingival level, supragingival. Also, the discriminatives or the grooves or undercuts of the pulp chamber, the gataparka, the sealer, whatever is there, has to be covered up with a 1 to 1.5 millimeter of a composite or a GIC, and then you prepare. This is the occlusal clearance that is performed, and this is overall uh, the scenario of the endocrown preparation. This depth, after you do the occlusal clearance, the depth at this pulp chamber level has to be at least 2 to 3 millimeters. It should not be like just 0.5 to 1 millimeter deep. No, it should be at least 2 to 3 millimeters. Okay, only then there will be that added retention feature that will be over your for your endocrown. See, this is like 2 millimeters of that depth, and beyond above it I have prepared this very nice looking occlusal groove anatomy. Yeah, of course, this is not my excessive strength of giving proper grooves and depressions and everything, but it's a learning phase for everyone. Now, which are the suggested treatments for the internal surface of restoration? That means now we are going to see the luting of this particular case, how to do the luting of the composites, composite inlays, onlays, or endocrowns. So first we have to treat the internal surface of the composite as well as the tooth preparation area. Okay. Most importantly, everybody would have at least 37% phosphoric acid in your clinics, very good quality ones. Okay. You can use those agents for 30 to 40 seconds and etch the entire internal surface of the restoration as well as the tooth surface. Best would be sandblasting with aluminum oxide, 27 micron or 50 micron aluminum oxide particles. That's called air abrasion. Those are specific special units that you need to buy. The costlier ones, the high-end ones, come around 80, 90,000 or 1 lakh as a unit. So it's a big investment. So in initial 1 or 2 years, if you don't want to invest in air abrasion units, what you can do is at least get them acid etched, or you can make them sandblasted to your local nearby lab if the person can come with that sandblaster, or if you can send your assistant to just 5-10 minutes away from you and he can sandblast the internal surface and come back. That's a good thing to do. Then you need to apply a silane coupling agent within the acid etched or a sandblasted internal surface of the composite restoration. Okay. Now these are the cementation. This is one of the only slide which is showing the cementation protocol step by step. Very important. Okay, please keep a note and note each and every step. The first step, as I told, ideally is sandblasting of internal surface as well as the restoration as well as the tooth. So this is the tooth and the internal surface of the inlay. If not air abrasion, then what you have to do, I already told you, you have to acid etch. So I have acid etched the internal surface of my endocrown or inlay or onlay. Now I am going to apply a silane coupling agent on the internal surface of restoration. Silane coupling agent, as I told, Bifix QM kit already has that ceramic bond in it, the silane coupling, or you can buy it separately. So you have to apply it. I ideally use 2 coats. Okay, one coat, then after 30 seconds apply another coat. Wait for 1 minute. Till that area or till that time, what you have to do is prepare the internal surface of the tooth inside the patient's mouth. Ideally, you have to perform it in rubber dam isolation because it's a delicate step. You don't need any saliva, any blood, any patient movements unnecessary while you are going to sit your inlay, onlay, or an endocrown because it's an adhesive restoration. It bonds or binds to the tooth adhesively. There is no much retention features that you can give in these restorations like grooves and all. Etching of the tooth bonding surface. Okay, so inside, this is my own case that we are discussing currently. This is so before etching you have to perform this. You have to separate the surrounding teeth with Teflon. Okay, I have not done here, I don't know what reason, because here there was some contact, here there was no contact. So etching, before etching you have to isolate the surrounding teeth with Teflon. Now, after etching of the tooth surface, you have to rinse with water, dry it, not over dry it, just dry it, keep it slightly moist. Then apply a 5th generation bonding agent. That's, I'm sure everybody has that in their own clinics. No need for 7th generation bonding agent. Unnecessary, the best bonding strength can be got from a 5th generation bonding agent. So apply 5th generation bonding agent. Then you need to wait for 20-30 seconds, then dry it, and now you have to light cure this area of the tooth. If you are using a dual cure bonding agent, which I told you, Futura Bond DC, 2 bottles, then you may etch, you may not etch. So if you are even etching or you may not be etching, you have to apply the bonding agent over the tooth surface, and now you don't need to cure. Why? Because this is a dual cure bonding agent. It will self cure as well as light cure along with the dual cure resin cement that you are going to lute with the indirect composite inlay, onlay, or an endocrown. So in those cases, you don't need to light cure the bonding agent. If you are using a 5th generation light curable bonding agent, you have to light cure. Okay. This is the Futura Bond DC. One drop of this liquid, one drop of this liquid, and then you mix it well with your applicator tip and apply on the tooth surface. Now is the time you apply this Bifix QM dual cure resin cement inside the internal surface of tooth if it's a onlay or an endocrown, and mostly inside the cavity or the tooth preparation. And then fitting of the restoration, or you lute the restoration. Now very important, once you sit your fit or sit your inlay, onlay, or an endocrown, a lot of extra cement will come out. Okay, that is now tooth colored. See, this Bifix QM is universal shade. That means it comes around A2 or A1 shade. So it's a universal shade. It can be done for A1 restorations also, and it can carry out the dentin shade up to A2.5, A3 restorations also, A3 shades also. So it's called universal. Now, whatever extra cement comes out, very important, you have to cure it for only 2 seconds from all angles. That is buccally 2 seconds, lingually 2 seconds, occlusally 2 seconds. Okay. And then that is called tech curing. And then remove the excess. That excess will come in a gel stage. So you can easily remove with an explorer or a spoon excavator. And then after you remove all excess, you remove this Teflon. Okay, so that Teflon will remove the excess in the proximal area also. You have to properly light cure the restoration with high intensity light from all surfaces, 20 seconds at least from one surface, 20 seconds occlusally, 20 seconds buccally, 20 seconds lingually, and 20 more seconds from the proximal part. And then okay, this all should be done under glycerin, okay, so that oxygen inhibition layer is not developed. And then finally adjust in the patient's mouth, the occlusal adjustment, and then finishing and polishing. Okay, so these are step by step. First etching is done, then that silane coupling is applied inside, and Futura bond DC dual cure bonding agent is applied over the cavity after etching of the cavity, and then the luting of the composite endocrown. So have a look. Overall, if you can see, because of the attrition, there is no much occlusal anatomy present in the patient's natural teeth. There is some attrition and everything is there. Hence, this is a very good alternative. A composite restoration would last for a long time and would be very convenient to the opposing arch, because ceramics would grind the opposing arch at 3 times the speed. And look at this shade matching. Now, in this case, of course, I had to perform that local cleaning of teeth also. So have a look at this shade matching. And main thing, here is the margin. Okay, so it is quite far away from the periodontium. So it won't lead to further deterioration of perio health for this particular teeth. Okay, this was the pre-operative X-ray. This is the endodontic treatment carried out. And have a look at this ultimately luting endocrown. It's having a healthy dentin over this area also. So in this real transformation from start to finish, imagine you show these pictures to your patient or your client after completion of the visit. If you have taken basic photographs, pre-operative, post-operative, he or she is going, not going to visit any other dentist in life other than you, because see the transformation that you have done for the patient. He or she will be very happy, and that also at not a very big cost, and in a one visit. You can't, she or he can't imagine more than this, can't ask for more than this. Another case of composite chairside fabricated composite endocrown. This is an upper first molar. Endodontic treatment was done. As you can see, after endodontic treatment, some amount of composite, flowable composite is filled up over the pulp chamber, the floor of the pulp chamber, and then this tooth was prepared for an endocrown. See, have a look. This is a 2-3 millimeters of the retention of the pulp chamber that we get. And overall, we need to keep a 2 to 2.5, 2.5 millimeters or a 3 millimeter clearance. See, this is the clearance. Her lower molar already had a failed, restoration, and as a result, please keep admitting the people. I think there are many people waiting. So this is the clearance that I got. Took the alginate impression, poured the disilicon material. See, this is the endo part of the endocrown that goes within the pulp chamber area, and this is the natural retentive feature. So this is the crown that I have managed to build up with composite. And the best part is the light can be directly kept onto the composite and it can be cured. So homogeneous curing can take place and it becomes excessively rigid. And this is the post-operative X-ray after luting of this crown. This is the endodontic treatment that you can see, which was performed. And have a look at this crown. Very nicely fitting. The client has not come to me for the lower teeth crown or any other treatment, because I knew she had come to me only because of pain regarding this teeth, and I had to motivate her even to do the root canal treatment. She only wanted some filling to be done. I am sure many of you would be facing such clients. So I carried out 2 sitting root canal treatment, and then because there is no crown and I am sure she's not going to undergo any treatment in the lower molar, hence I am not performed a regular crown. And have a look at the periodontium condition, also not that good. So better that it does not deteriorate further. Another case, a very good case. This client had to leave for a foreign trip immediately in 2 days, and she came to me with pain, so I had to perform this single sitting endodontic treatment. And then later on in the evening or next day, I think I called the patient for the crown part, because she came in late evening, I think, on the first day, and then second day morning I called her for, because doing a single sitting RCT properly for this curvature kind of case. This was not a regular easy case. It takes 2 hours for the single sitting root canal treatment to do under rubber dam isolation, and then 1.5 hour for this cementation, the fabrication of endocrown and the cementation. So it takes a toll on you. So do it when you are fresh. This is the endodontic treatment that I did, single sitting, as you can see. This is the temporary restoration that I gave. Patient came next day. I prepared the occlusal clearance, as you can see. This is the alginate impression. This is the disilicon. Over that, I built up the endocrown. And as we discussed the cementation protocol, etching after Teflon isolation of the surrounding adjacent teeth, etching of the tooth was done. And I applied the dual cure Futurabond DC. Yeah, Futurabond DC, if you have, they don't recommend, I mean, they don't insist that you need to etch the tooth surface, but for my own better, because we don't, I mean, personally, currently I don't use sandblaster or air abrasion instrument in the oral cavity. So at least I need some basic more etching of the enamel. And then after that, using Futurabond DC, not curing it, and using Bifix QM to lute this endocrown, and then curing it, tech curing first, removing the extra, and then curing it properly under glycerin. So see, this is the final endocrown that has been prepared. Now have a look at this image and this image. This is finished polished image, okay guys, and this is a glazed image. So very important material is easy glaze. It also fortunately comes from Voco. Easy glaze is kind of a varnish that you apply over the entire restoration, which gives glaze. The initial 24 hours it inhibits the water or the oxygen inhibition, and the micro leakage and everything, it reduces to severest levels. Okay, so easy glaze is one of the kind of bonding agents or a dental varnish that you can apply over the restoration and at the margins, and cure it for 30 to 40 seconds. See this final entire restoration. Single sitting root canal of this tough case. There is small divergence bifurcation of the apical part in palatal, distal curvature, and this very nice looking composite endocrown. Slight shade matching difference here, but because of some hypoplastic area that patient has, that's the reason. But very nicely functioning. I think I did this around January time or maybe December time. So it's almost 9 to 10 months. It's working fine. One more such endocrown preparation, as you can see. Now this, some cases where you cannot perform rubber dam isolation, what you can at least do, especially for the upper teeth. The lower teeth would be very tough to perform isolation with cotton roll and carry out the regular cementation. But for the upper teeth, salivation is not a major issue, right? So you can place a cotton roll here. You can do isolate the adjacent teeth with Teflon, and then carry out the cementation protocol for this endocrown. This is the final. This is the final. So this was my article that we published in 2016 in Journal of Research and Advancement Dentistry. Post endodontic restoration with novel endocrown approach. Okay, I am one of the author. It is showing my cases, but this was not for the direct composite. It was for indirect ceramic endocrowns. What would you do for this case? Okay, why I am showing this case as one of the last case, just to show you and just to motivate you that looking at x-ray, sometimes we jump to endodontic treatments. Okay, even if patient does not have any complaint regarding sensitivity, or patient has just come with food lodgement, or my teeth has fractured, please build me up, etc. Some people may even remove this teeth, and maybe they are thinking of a bridge or an implant and all that stuff. But this was a young patient. Have a look. Even the third molar has not erupted, or I think has not, not there only. So in this case, entire this eroded part, this arrested caries part was removed. See, no pulp exposure. but it was a wide one. There were no cusp remaining, only one cusp was remaining. And thankfully, it was healthy somewhat. So what I did is I sealed the all the dentine part here, as you can see, with healthy enamel all around. And then I made a, no doubt this was a ceramic onlay. This case was performed 2.5 to 3 years back, actually. Look at this. And then this is the cementation. Treatment was done 2 years back. No sensitivity, X-ray is normal. Okay, so I conclude my presentation, my slides with my work and worship place. Worship, our workplace should always be our worship place. Only then, we can uh, do justice, ethical, honest dentistry towards our dearest clients who trust us and come to us for their treatments. So this is my A to Z Dental Solutions, my clinic with a 4 dental chair setup, in-house OPG X-ray center, digital scanner. And this is my academy where I have these control boxes. And this is a completely separate academy room where I have completed 28 batches of endo workshops till now in past 5 years, and 6 batches of composite workshops till now. Our academy was also awarded in 2017 with under the award with Best Dental Academy of the Year. Values aren't taught by what we say, but they are taught by our own example. Okay, so this is me, Dr. Pathik Patel. My mobile number, my cell phone number, if you want to reach to me regarding this aspect, regarding any composite restorations, or even a further session post-COVID era. Of course, we will plan out to come and teach this specific thing with demonstrations, hands-on, everything live, as well as very important other topics of composite that I have on sensitivity part, how to create a sensitivity free and a stress free restoration. That's a very unique presentation. So you can stay in touch with me. Thank you very much. And this is me. Now I'll be open to take some questions if people have. And thank you for having me, IDA Malabar branch. Uh, Kerala is a beautiful city, beautiful state. And I already visited Kerala uh, last year only, around October, November time. And I hope I can get a chance again after maybe 1.5, 2 years when everything is under control. I wish all of you a very safe, healthy life and dentistry. Please take precautions in doing dental treatments. Wear your autoclavable gowns or surgical gowns. Uh, Proper sanitization. Most important last tip I will give you: if you want to be safe from your patient's virus, if he or she is having an asymptomatic carrier, make them do H2O2, hydrogen peroxide, or betadine gargles in throat for 15 to 20 seconds and in mouth. And then after that, carry out chlorhexidine gargles, same way, 30 seconds in mouth and 15 seconds in the throat. And then start your procedures and try to complete the procedures within 1.5 hours. If it is taking long, make sure that you perform these gargles, mouth washes again. Thank you very much.
Thank you, sir. That was a beautiful topic, beautiful presentation, and full
You.
filled with facts and tips. Very good, sir. Thank you. Now, if anyone has doubts, they can unmute themselves and ask. So, I have a doubt. Why
Please.
tell about overlays, tabletop restorations? If in case it's not just if it does not require endo restoration, you are not encroaching into pulp chamber space. Why can't we place a tabletop restorations?
Definitely, you can place a tabletop restoration. You can place, like my last case, it was almost like a tabletop restoration. So
Yes,
that,
sir.
because before 2.5 years, this material was not into market. I mean, it had just initially developed. So there were the other techniques that we used to do for composite restoration, in which we used to prepare, take the impression. We used to prepare die model that is out of stone, and that we used to prepare the composite separating media, composite restoration. I have done such kind of cases in my post graduations. Then we used to autoclave those composites to increase the strength, give that heat treatment.
Hmm.
etc.
Okay.
So, but anyways, that was little, it actually took 2 3 visits, some more investment from your part, and not that highly proven. So
Okay.
I did ceramic inlay only. But yes, tabletops can be done with this particular restoration, this technique.
So, okay. So all the composites that you described today were all light cure composites. They were not heat cured. Something like that.
No, they were not
Were
heat
they?
cured, because heat cured composites, I had lab fabricated composites, most of
Yeah,
them.
they're lab fabricated. Yes, we
So
are
the
discussing that.
same thing is that you need 1 2 3 days for the process to come. So what about who needs immediate treatment, right?
Yes, sir. Right. So another problem which I have encountered is that when I try to take impressions of the pulp chamber space, usually air bubbles happen in that. I'll have to make a dual pore impression of alginate. Yes,
Yeah. So what you can do, I mean, for this direct, semi-direct technique, as I told, that the pulp chamber space should not be very deep. Otherwise, how will the alginate go that deep, void free, and it will
yeah,
come back?
yes,
So,
sir.
and you know the flexibility of alginate, right? It's not extremely
Mhm.
rigid.
In case
Hence,
of
in such,
composite, yeah, in case of addition silicon light body, it will go easily, but
right.
alginate
So,
is
so
tough.
in such cases, you have to make sure that the depth of the pulp chamber that you are keeping for endocrown preparation should not be more than 3 millimeters, and it should have a good amount of 8 to 10 degree taper, and it should not have
Divergence.
any grooves, or that's why you have to fill it up with a flowable or a GIC layer at the base of the pulp chamber.
Right, right. So for that deep margin elevation, GIC is enough, or do you
GIC,
need to have go for
GIC is
that?
enough, but I would prefer you a stronger GIC rather than a routine GIC, restorative GIC. Why stronger GIC? Because at that point your composite inlay is going to stay above it in contact.
Yeah,
So you do need something which is near strong, if not as strong, that of the semi-direct inlay that you have prepared. So ideally it should be a stronger GIC, like Ionolux, that's a light curable GIC from Voco, or Ionostar Molar, Ionostar Plus. Those kind of strong GICs which are having compressive strength of around 250 MPa. Or you can have that, you can do with your regular strong flowable. You cannot do the margin elevation with a regular flowable composite, which is having high shrinkage and less strength. You should have a Grandio SO heavy flow, or Everex flow, or kind of uh, other flowables in market which are strong enough.
Everex flow can be used, can be exposed to the oral cavity. It
Yeah,
has
it
got
can't
that
be
fibers,
exposed.
right?
It
So
can't be
they used to
exposed. So
stain.
you cannot use it for deep margin elevation at the gingival seat area, the enamel
Yeah,
area. You can get it done at the axial level, but not at the seat level. It should not be exposed to oral environment. Otherwise, it will create roughness and you can't polish it.
yes, sir. Another question, sir, I had saline treatment is usually for ceramics, right? It has
Yeah,
got
it's
the
usually for ceramics.
glass phase, which it has got the glass phase. So composites, how does saline work there?
Yeah. So for composites, uh, it's tough to explain that how the silane would work, but it is indicated for semi-direct chair-side composites in most of the research articles, and as well as for this particular technique that has been developed by Voco with disilicon. And each and every article is showing, even for the direct chair-side composite inlays, to use the silane coupling treatment, because see, eventually this composite is hard composite with minimum monomers left,
Right.
and the internal surface, because you are sandblasting, you are etching it. Otherwise, as compared to direct restoration, still there is some gap in the bonding mechanism, because this is an artificial composite made thing, and this is tooth, and you are luting
Okay.
with another layer. So they have indicated the silane coupling, and uh, even for post, when you lute a post, even if it's a fiber post, you ideally have to silane the post before luting it. That is also many articles say. So for almost all indirect procedures that you're doing, the things which are outside mouth, it's better to treat them with silence.
Okay, sir. Coming to the questions from the participants, one doctor has asked, uh, how much can it be detached after some point of time? This restoration, how long does it fail? Uh, I think that's what the doctor.
So the first restoration that I have performed, this semi-direct restoration I have performed in my office, is around 1.5 years back. More than that, actually, almost almost near about 2 years, and it has not fractured or detached. So, but yeah, what you can think is it may not last for like 15-20 years, but it's more like a semi-permanent restoration or near permanent restoration, which I feel would last minimum 5 to 7 years. I don't know more about that because eventually time will speak. But till one and a
Yeah.
half, 2 years, no of my client has come back with any single fracture or sensitivity regarding that case. So that what I can say.
The another doctor has pointed out that we can take IOPA before cementation and check whether the margins are correct. Right.
Yeah,
That's
so
also a good
I
tip.
would prefer doing that. I just missed out that point on the tips and tricks. So thank you, doctor, for just giving me that point.
Yeah.
Yes, ideally, even for crowns, that is what I do in my practice. Even before luting a crown, I take an
Yes.
IOPA, right? Because sometimes there are some marginal discrepancies that we find after cementation, and then this case is ruined.
Yes, sir. So
Hmm.
one another doctor has asked about the charges and how much can we
Right,
charge from the patient.
right. Very, very important. Very nice
Regular.
question. See, for charges, what I do is if I have to do a direct class 2 restoration, for example, I charge around 2000, 2500 or 3000 rupees, depends on the depth. If it's a premolar or a molar, if it's a first molar, second molar, depend on the feasibility, access, etc. So maximum I charge 3000. So 2 to 3000 rupees for the direct class 2 restoration. For the indirect restoration, if you are going to perform indirect ceramic inlay onlay, you have to charge minimum 9 to 10,000 because 2500 rupees is lab cost plus your
Yes,
A
sir.
silicon, C silicon impression material, your cementation protocols, etc., etc., etc. For this particular restoration, I can charge around 4.5 to 5,000 rupees to the patient, which is quite near about my direct restoration charge. So the patient just has to pay 1.5 to 2,000 extra rupees in that, because I am not going to spend much on alginate impression, as you know. We are not going to create an opposite arch impression. So no other another alginate needed. And disilicon material, uh, you know, exactly I don't know how much it costs, but there are a lot of models that you can prepare from a single syringe. Lots and lots of models. So it would cost you around 100, 150 rupees for a single model maximum. And then you can lute it with bifix QM kind of material, which is little costly, but it's one of the best in market. So if that you can use even for luting veneers or crowns, and so it's a multiple use thing. You can use any other dual cure resin cement like paracore or something like that, which is economical in the initial practice, or you can use a flowable composite.
Yeah.
It's around 5 to 600 rupees extra that you may incur on your end. But the main part is time. Lot of time will be saved. No, you can do it on the same chair side. You can, some doctors even charge 8 to 10,000 rupees like that of ceramic inlay onlay, because they are giving their extra time, extra skill, and performing that, in that same visit, and giving the patient 1.5 to 2 hours of their important time. So that's on your end, how much you want to charge.
Yes, yes, exactly. Any other questions, please ask. You can either put it in the chat box or you can unmute yourself and ask. Anyone? So we can't use this with flow, this putty and addition silicon.
No. I have already tried that and it
Yeah.
miserably failed.
Right, sir. In that case, we could have taken that triple tray technique and then got the opposing occlusion also.
Yeah, that can be done, but opposing occlusion, I would prefer that you can take another alginate impression. And while you are performing this half-an-hour procedure of this disilicon pouring, then above it layering and everything, some finishing, polishing, till then the assistant or your
And pour it,
whosoever is
yeah.
there, staff person, can pour it with stone, and in 20-25 minutes can remove it. So you can at least outside, if you know the patient's bite, you can 80% create that occlusal clearance, proper adjustment.
Here, I think even the entire arch impression is not needed. You only need a sectional.
Only
tray.
3 to 4 teeth area, and if you want to take the opposing
Yeah.
arch impression, to manage the adjustment, then you need to take that 5 to 6 teeth. So only quadrant dentistry.
Yes, sir. Right.
Hello. Hello.
Yes, sir.
Yeah.
Yes.
I got a small doubt. Yeah.
Tom,
If
sir.
for endocrown, as you said, like it's maximum 3 millimeter depth you can go. If we go beyond that 3 millimeter depth near to pulp, base of the pulp chamber, is there any other issue rather than air entrapment?
No other issue can occur if your alginate impression, if you have a high precision alginate impression material, and if you are adding that alginate with your plastic filling material inside the deep depth of the cavity before taking the impression, and then you load onto your tray and press it properly, and if you can remove it in proper shot without much of disintegration of alginate, flexibility problem of alginate, then you can work out. But as deep it is, sir, what happens is many of the times it is not as easy that you can see in the post-operative x-rays or post-operative pictures. There is some a learning curve that you face in initial 10-12 cases where there is a lot of adjustment that you have to do, because the disilicon, the direct, indirect, I mean semi-direct inlay onlay endocrown that you prepare on the disilicon, it may not properly sit exactly inside the tooth. You may have to, initial cases I had to adjust for 45 minutes, 1 hour before it set. So as deep it is, there are more chances of problems.
Okay, thank you, doctor. Anyway, it was a very nice presentation and very eye-opening one. It's
Thank you so
easily we
much.
can adapt. It's easy to adapt to our clinical this thing. And as this Corona time, people may prefer also one sitting. You finish it off all this crown or prosto part. That'll be very good. Okay,
Yeah,
thank you,
so
doctor.
most of the last 3 to 4 molar cases that I showed you, most of them have been done post-COVID era, so post-lockdown era. So yeah, they have turned out to
Yes,
be
sir.
very useful to me.
Okay, thank you, doctor.
Yes, there are a lot of posts, a lot of comments saying thanking the presenter, thanking you, sir.
Most welcome.
Then that we had around 37 participants in the Zoom meeting and over 42 participants through YouTube Live. That's about it, sir, I think. Any other doubts? You can unmute yourself and ask. Otherwise, I think it's 11:40 almost. More than 1.5 hours.
So can I ask some questions to my
Yes,
dearest
sir.
participants?
Yes, sir, definitely, sir.
Okay, if anyone wants to reply me, can unmute and tell. So hopefully you all are using good quality whatever company materials that are there. So do you have any problems or doubts regarding the bulk fill or high strength materials that you may be using? Because or eventually this inlays or onlays or endocrowns can't be prepared with your high shrinkage micro filled or micro hybrid composites. They have to be done with nano hybrid, bulk fill, or strong materials, and they will be some investment to you. You cannot use regular composites and just make sure that it will stay for many years because of the shrinkage, strength, etc. So any doubts or any which are the maximum people going to use composites in their clinics? Because some areas, some materials are more used. That's what I have heard. I have in my visits to various states.
Currently,
If
sir, I
Dr.
have
Krishna, you only,
yeah.
yeah, you
I think I have the Zemorex posteriors fiber one,
very nice,
which I
very
use
nice.
for build up. Yeah, and then
Okay,
this guy. Yeah, I also have that extra fill compules, which I use with heated. I heat them and then use the. Those are the two things which I.
so what's the reason
So
for
you told
heating extra
something
fill, sir?
so that a bit it gets a bit more flowable.
So I'll just advise you, when a material is already of having a very thin consistency, like extra fill is not a very hard composite. When you when you condense it,
Okay,
you would know that.
right.
So when a material has already been made with a more of thin or a flowable type consistency, better not to make it more flowable. And what happens is when you give heat, it will shrink more because of more monomer conversion.
Okay, right.
So that's one of the advice. You can heat a hard composite because it's a low shrinking composite. A hard composite is a low shrinking composite. Only then it will be hard because of high filler content. So
Okay, right.
okay, so I think if nobody has any question or any reply, then I think we can
Yes, sir.
conclude the presentation.
Okay, so it was nice having you. Very a lot
Thank
of
you.
thanks for this very wonderful presentation, sir. Thank you, thank you.
Most welcome. Most welcome.
Please do visit us if you are after this corona. If you're coming on anytime to Kerala, so just give me
Definitely.
a call. Yes, sir.
Definitely. It was very nice talking to Dr. Krishna and all
Thank you.
the chairman and organizing
Person.
committee of IDM Alba. Thank you.
Thank you. Thanks, sir.
Yeah.